Um, Thank you very much for the introduction. I would like all attendants just to bear with me. I want to ask you a question. مين في حضراتكم شاف حالة أكيد cardiac amyloidosis؟ Hello? 1, 2, 3, 4. Okay, I'll give you a good number. All of you have seen cardiac amyloidosis, but it went under your radars. This is what we're talking about. This is an important session that we're talking about a disease which is not rare. I'm not saying it's very common, but it's not rare, and it is always masquerading. So this is my disclosure. Of course, this is on behalf of Pfizer. And I'll show you a patient. This is a gentleman who's 54. He's an ex-smoker, coming with progressive shortness of breath, fatigue, and treatment for peripheral neuropathy. Okay? He's not overweight. You can see his body mass index is great. Blood pressure is controlled with an elevated JVP. Yesterday, today, we're just putting back what's more important, clinical assessment of our patients. And heart failure is clinically assessed. If you look at the patient's symptoms and signs, they are typical and specific for heart failure. Whether it's reduced, whether it's preserved, whether it's any type of heart failure, this is heart failure symptoms. It could be other causes, but this is important. So what to do? Usually we go on to other investigations. This is the chest X-ray of our patient. You can see maybe a little bit of congestion, pulmonary venous congestion, not so apparent. The ECG actually is, shows T-wave changes, left axis deviation, nothing really specific. It looks maybe like an ischemic patient actually with the T-wave inversions. But if you look at the echo, functions are there, are good. The left ventricular wall is thickened. It's concentrically thickened. There's no segmental wall motion to say that this patient is ischemic. Of course, this is not a criterion to exclude ischemia. Left atrium is markedly dilated with an increase in the right ventricular pressures. So what does this patient have? You remember the LVH we saw in echo? Why is it not appearing here in the ECG? What's so striking about this ECG? It should have left ventricular wall hypertrophy in the ECG, which is also an important thing. There's diffuse ST changes, first degree heart block, if you look closely, and the low voltage ECG, which is very important. What does the patient have? So let's take a look at other investigations. Actually, the renal functions were normal, not anemic really, normal hemoglobin A1C, but the end-terminal pro-BNP is quite elevated. And this is another hallmark to diagnose heart failure. Of course, in this case, this is heart failure with preserved ejection fraction. And if you look at the echo parameters, which can be easily done using most machines that are present all over the world, this patient, it's not diastolic dysfunction. It's called a preserved ejection fraction criterion, like the E over E prime and the left atrial volume index. They are increased, and this is a case of heart failure with preserved ejection fraction. So heart failure is, increasing. We've heard a lot today. We've heard a lot yesterday. We're going to hear a lot every single day of our lives because it's increasing in prevalence. But the thing is, are we getting to what is the cause of heart failure and how we are managing it? This is important. And we think of amyloidosis as something which is very rare. It's a disease. It does not affect just one single organ. It can affect the multitude of organs, like the soft tissue, the liver and spleen. Of course, it can the eyes, the pulmonary, whether the circulation of the or the lung tissue itself, the GIT or the nervous system. So it's really a big disease that encompasses all organs. And the types, I know this really is a little bit going back to medical school, but the types of amyloidosis are actually two major types and very rare types. The two major types are the AL amyloidosis or the light chain, which is very serious. This is a medical emergency. The patient here will die within 6 months if he has cardiac or she has cardiac involvement. 6 months. The mortality is higher than that of any other type of heart failure or ischemic heart disease. The other type, which is more commoner, is the TTR or the transthyretin amyloid cardiomyopathy. And this, including the AL, have 95% of all amyloid. Of course, there are other causes which are quite rare. So the AL type, it originates in the plasma cell. It's a plasma cell clone that infiltrates the bone marrow, and it has severe affection and very high mortality, and it usually presents above the age of 50. And it, when diagnosed and when there is cardiac infiltration, the mortality is quite high. These amyloid fibrils are deposited in the extracellular tissues, whether in the heart or other organs like the tongue, causing macroglossia and stuff like that. So it's a monoclonal plasma cell population overproducing these immunoglobulin light chain fragments. They misfold to form the fibrils which deposit. And it's equal distributed between males and females. Usually in the elderly age, you can see the low QRS voltage criteria, restrictive or HFpEF cardiomyopathy can be seen, but with cardiac involvement, I should stress here, the mortality is less than 6 months the patient has to live. So this is even more serious than most of our diseases. The ATTR, or the transthyretin amyloid cardiomyopathy, encompasses a totally different thing. It's mainly from the liver. It's not the bone marrow. And again, there is misfolding on aggregation into amyloid fibrils which deposit in the cells. And this is, more commoner than the AL, less serious, but it is serious and it is present in a lot of patients. The transthyretin is subdivided into two types, the wild type or the genetic or the hereditary type. So it's either wild or the hereditary. And the prevalence is different, of course. It's very important to take that the ATTR, the wild type, accounts for 13% of patients with HFpEF. 16% of patients going for a TAVR, aortic stenosis, have amyloid disease. So if you think you did not really go over a case or see a case of amyloid disease, you probably did, but it went just under your radar. The prognosis is a little bit better than the amyloid or the AL type, and it's around 3 to 4 years. Of course, it is progressive, so you should take care. And there are different, what we call phenotypes, different phenotypes between the hereditary and the wild type. It depends according to the age, the dominance, and of course the cardiac findings. The conduction disorders are much more common in the hereditary type, especially the one with cardiac involvement, because there are hereditary types with more prevalence of nervous cell involvement. And the wild type is very common to see heart failure in over 50% of cases. And there is an increase because we have better diagnosis, we have better tools to understand, we have better knowledge that there is an increase in the hospitalization trends for cardiac amyloidosis. If you look over the past decade, it's increasing because we are getting there. What are the signs? We said heart failure, yes, but very commonly you can get other things, bilateral carpal tunnel syndrome, spinal stenosis, lumbar spinal stenosis is to be exact, soft tissue infiltrations, of course, in the hereditary type or the ophthalmological. So these are really some of the red flags of the clinical diagnosis of ATTR cardiomyopathy or amyloidosis. So number one, you have to have a high degree of suspicion to diagnose, especially if the patient has a history of bilateral carpal tunnel syndrome, a family history, especially the hereditary type of heart failure. And if the patient is getting heart failure treatment and is unresponsive, patients taking medications get severe hypotension or is not getting responsive. This could be due to the autonomic dysfunction in this disease. So we go with the ECG. You see in our patient's ECG, you see the pseudo-infarct. There is no LVH. It's a low voltage ECG in spite of the left ventricle actually having a thick myocardium. There are lots of arrhythmias, especially atrial arrhythmias, and some conduction blocks. We've seen lots of ranges of heart blocks. The echo shows an increase in the left ventricular wall thickness because of the deposition of these fibrils. Very commonly an increase which is around 15 millimeters, which is quite high for a patient, not like that in hypertension, which the LVH in most cases is a little bit subtler. And usually the global left ventricular functions are preserved unless later on they go into HFpEF, half mid-range or mildly reduced, then half ref. And what is very good here, and we discussed this yesterday, the global longitudinal strain. Global longitudinal strain is a very good way of diagnosis of HFpEF. It's one of the criteria actually in the scores. But here in amyloid, it has a specific thing. It shows apical sparing. The apex is spared in most cases. And these are just pictures of what you can see, whether the diastolic function, which is impaired, the E over E prime, the left atrial volume index, which is increased, and the apical sparing we see in global longitudinal strain. Can we do more? Yes. We can go for a cardiac MRI, and this is, of course, very diagnostic for myocardial disease. And it can show different types, and there is a score actually for the types of the prognosis of amyloidosis according to MRI and the radioisotope scan. Are any blood biomarkers are important? Actually, there are. You have the blood biomarkers of heart failure, like the N-terminal proBNP or BNP. Troponin is elevated, and these, as much as they are elevated, this shows the prognosis of heart failure per se and amyloidosis also. But let's take a look on how to do it, because I've seen a lot of data. I want to know how to do it. If we have a patient who has heart failure, some of the clinical criteria like carpal tunnel syndrome, increased wall thickness in the echo, it's a male above the age of 60 or a female above the age, later it's the older ages especially, we should go. And here we can do, of course, an MRI, an echo is already done, a bone scintigraphy. And a bone scintigraphy, which is cheap, simple, and will easily diagnose or not miss a lot of patients. If that is positive, we can go for the more serious diagnostic criteria for AL amyloidosis. So bone scintigraphy, which is a very highly sensitive imaging technique, and it can localize TTR cardiac amyloid deposits, and this will help us not miss a lot of patients. And this is another picture of what we see with bone scintigraphy, and it can easily show us where is the extent of the disease in the body. Ruling out amyloid, which is of the light chain or the AL type. Why? We said it's a medical emergency, and the survival is 6 months if there's cardiac involvement, and this is very important. And here, the test with the highest sensitivity is the serum free kappa lambda light chain ratio. Here it's very important. And of course, immunoelectrophoresis, and this is a medical emergency, not for us to send to the hematologist that they will treat. We're not going to treat them. They will treat them. A biopsy, which was used years and years ago as a definitive way, cardiac biopsy, lung biopsy, rectal biopsy, we don't need them anymore as much as we used to because we have very sensitive other non-invasive or non-intrusive investigations. And genetic testing, if the patient turns out to be the hereditary type, we have a wide range. There is the more cardiac types and the more neurological types, and we should cascade screen their relatives because it can occur in families. And we said a family history of heart failure could be indicative of amyloid disease. This is quite important. So we have a lot. Don't, waste your investigation. Use them. You have them. And they do help us really look at patients and get them. And even an algorithm proposed by Duke University saying that we should look at the first one on the left, clinically. What we are forgetting is the clinical sense that we have. ECG and echo and an MRI. Of course, some centers go for bone scintigraphy, which is cheaper, more available, and sometimes better. Sometimes, okay? And then we go on to, if the amyloid is diagnosed, to rule out AL amyloidosis because of the seriousness, and then if it's ATTR, which is the less serious, but very serious, of course, then we can really go into the deeper investigations, whether it's going to, and re-diagnose it if it's wild type or the hereditary type. So these are the ruling out of the AL amyloidosis. I really reiterate how important it is. So to take away, this is a nice algorithm I borrowed from one of the key speakers of amyloidosis all over the world. It's called HIDDEN. The H is HFpEF because it's always, nearly always starts with HFpEF or heart failure with preserved ejection fraction. The I, intolerance to standard heart failure therapies. You expect a patient with heart failure to take a RAS blocker, a beta blocker, and get better. But sometimes they do not because of the autonomic dysfunction. The D discordance between the QRS voltage and the LV wall thickness. You see a thick myocardium on echo and, you know, very poor R wave progression on ECG. Diagnosis of neurological disorders like carpal tunnel syndrome or lumbar spinal stenosis. Yes, it could be a lumbar disc, but it could be amyloid too. The echo showing the increased LV wall thickness, regardless of the blood pressure, you would expect, you know, with the blood pressure of those patients with amyloidosis not to be so thickened, but you see the discordance also between the thickened myocardium and mildly elevated blood pressure or even low blood pressure. And the nervous system, especially the autonomic nervous system, including gastrointestinal complaints or even weight loss, which is unexplained. Why are we talking about this? Because if we do not diagnose amyloidosis, the patients will slip by, and we've seen how much mortality is prevalent in these cases. And if usually we misdiagnose them as other conditions in other sites of the body, like aortic stenosis, and we go, okay, so what? He has aortic stenosis, and they get a TAVR, they're not doing well, they're getting more heart failure, and they find out it's an amyloid disease, for example. Same with spinal stenosis. They go for surgery, they're not doing well, they get cardiac involvement, and then they go worse and worse. And delaying patient treatment may affect. And this is important, because I know you're saying, so what? He or she has amyloidosis, what do I have? Is there any good prognosis which I can get for the patients? Actually, yes. Just recently published, and a lot of medications have been used for amyloidosis, but I'm not going into this detail because it's beyond the scope of the presentation, that controlling or stabilizing these tetramers or the misfolding that occurs has reduced both mortality, has reduced hospitalization, has improved patient outcomes in everyday life. And the number needed to treat, I do not want to exaggerate, is 4 to reduce hospitalization, 7 to reduce mortality. These are numbers we have not seen anywhere. So the patients, when diagnosed, the AL type, of course, this is a hematological emergency, and they will treat with chemotherapy and other medications they see. But the ATTR type, there are medications that have reduced mortality, have reduced hospitalization, and have improved patients' lives. So my key message is, cardiac amyloidosis is not uncommon. It's under-recognized. We've seen it. I showed you at the beginning, only a few people raised their hands that they saw a case of amyloidosis. I can assure you, nearly all of you have seen one, but it just slipped below your radar. The ATTR is one which is not only diagnosed as a single disease like aortic stenosis or any type of heart failure, it could affect a lot. And the awareness of the clinical signs and the difference between ECG and echo, the discordance and the hidden criteria they put. It's not an algorithm, but it's a nice acronym. And we do not need a biopsy like what we read in medical school. No, we can do it with some bone scintigraphy. We can do it with echo and ECG. And if we want to rule out AL amyloidosis, the blood examinations and urine examinations are quite simple and done in nearly most labs. So please, look a little bit more in your patients. Ask them for more and more their different symptoms and signs in different parts of their bodies, because sometimes you might save a life. And thank you.